Colleagues, good afternoon and welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. As usual, this meeting is being broadcast on the Council's YouTube channel, Hillingdon London, and my name is Keith Spencer and I'm the co-chair of this board with Councillor Jane Palmer. So the usual, some housekeeping before we start. Please ensure any mobile phones around you are silent, unlike myself at the last meeting. And we're not expecting a fire drill, so if the fire alarm does go off, please follow officers out of the building. And again, as usual, please keep your microphone muted when you're not speaking, and then unmute to speak. You'll be able to check the red light is on, you're not muted. Okay, so welcome. We'll move on to the agenda. So do we have any apologies for absence, Nikki?
Chair, we've had apologies from Councillor O'Brien, who will be here, she'll just be slightly late.
And do we have any declarations of interest? I will take silence as consent, so that is good. Let's move on to the minutes of the 10th of September 2024. Was it really that long ago when we last met? Doesn't the world change when you're enjoying yourself? So does anyone have any comments on the accuracy of the minutes? If not, can I assume that these are agreed? Again, I'll take silence as consent. Okay, thank you. And then point 4 about exclusion of the press and the public, and I can confirm that items 5 to 9 will be considered in public and items 10 to 11 will be considered in private. Okay. Break with a bit of tradition. Do you just want to say just a few introductions? I think might be worthwhile. Leslie, I'll come to you in a moment, because I think you're well known to most people around the table. I'll start with Faisal. Faisal, do you want to?
Yeah, absolutely. Hi everyone, very nice to meet you all. I am Faisal Patel. I am the Head of Strategy for North West London, ICB.
Thank you, and you're very welcome to today's meeting, Faisal. And Leslie, welcome to your first meeting as well.
Sorry, and an old dog that still needs to be taught new tricks. Thank you.
Okay, if we can move on to the agenda item number 5, which is the Pharmaceutical Needs Assessment Update, and I think, Kelly, this is your agenda item.
Thank you, Chair. As a board, we are aware that we're responsible for the Pharmaceutical Needs Assessment to be reviewed every 3 years. This is a statement for pharmacy services in Hillingdon. And it is something that we have seen in the past. If you recall, Naveed used to present the one 3 years ago. So the P&A is a responsibility that was passed to us back in 2013. It assists the commissioning of pharmaceutical services to meet local priorities, and NHS England use this particular piece of work to look at needs in different areas and determine whether there is the right level of pharmacy access to a local area. As I said, it has to be reviewed every 3 years. The next one is due to be published, it has to be published on or before the 1st of October. There is quite a high fidelity in terms of the process for this P&A. It's being done in-house by the business intelligence team within the council. They are on track to deliver this by the 1st of October. It's currently in the stage where the first round of pharmacy questionnaires have been distributed. We've got quite slow uptake, so we're working with the LPC to try and increase the number of returns we have. This allows pharmacies to tell us what services they're currently providing, and it allows us then to map which services, wider than just pharmacy services, are being provided across the borough to see that there is a useful spread and access to those services. And one of the key areas that we're looking at is that pharmacies are accessible in terms of public transport and are accessible within a 20-minute travel time to all residents in the area. And as many of us know, this was an area that the Select Committee of the Council did look at some few months ago to determine whether the level of pharmacy provision is is adequate enough. But this particular document is that document to do that. Since the last pharmacy needs assessment, this document outlines that 5 pharmacies have closed down, and Kim Overy from the BI team has sort of given us a little bit of a highlight as to where those pharmacies are. That doesn't tell us the full picture. Again, the criteria for ensuring access and availability of pharmacies is something that this document by the 1st of October we will look at. Following this initial piece of work at determining what the pharmacy provision and the services that are coming out of pharmacies is, we will go out to the public as part of this kind of statutory requirement to ask them about their local access use and the positive parts of that local access use and the challenges that they experience. So Kim has helpfully put in the next steps. This is overseen by a steering group. We've had an informal steering group that's leading this initial provision of work, and one of the areas that we have been looking at is doing the update on the demographics and epidemiology within the borough. This is the kind of information that our later board report on the health and wellbeing strategy will take into account, and we'll look at whether the needs are different from when we last published a report. And obviously we know that things have changed. As I said, there will be a statutory consultation with the public. That has to be at least 60 days, and we'll continue to engage with pharmacies throughout the process. What I would say is the LPC are represented on that steering group. And so I just want to provide assurance that the process is going according to plan and that we aren't meeting the statutory requirements for this. Thank you.
So I take from this discussion on, Kelly, this is for noting at this stage with obviously the findings coming later in the year.
Yes, that's true. That's great.
Okay, any questions from members of the committee? Don't kill me in there. So I've got one question, if I can, Kelly, is just what's the relationship, I'm sure there is, between this and the neighbourhood development work that we're doing in terms of the 3 integrated neighbourhoods and obviously the whole pharmacy first and that link with that neighbourhood work?
Neighbourhoods should be using this as a kind of a useful tool to look at resources in their areas. It's a statutory document, it's a statutory review, but it should be informed as part of an asset approach to neighbourhood teams.
I don't want to put you on the spot, Eddie, but are you familiar with this work or engaged in this work from a concept point of view?
I'm familiar with it because I was here last time around when the previous document was published. We have been mapping and sorry, Kelly was trying to indicate to me what I was not doing and I missed it. Yeah. Apologies, Chair. Do I repeat myself? Aware of the documentation and the process, each of the neighbourhoods has mapped out and has got links into local pharmacies. There's still a lot more work to do though.
Leslie.
Thank you, and I was going to ask that actually, but can I suggest it's just because I don't know. It says here we've given all pharmacies a questionnaire with 10 questions. What sort of thing? Not all 10 questions, but what sort of things are we asking the pharmacies?
It's the statutory requirement is to ask them about opening times and about making sure that there is a registered pharmacy on site at all times, and the additional services that they provide, whether they're providing things like stop smoking services, health checks, emergency hormonal contraception, that extended offer, and then we're able to map to see where that extended offer is provided, to see whether there are gaps in that kind of wider provision that you would want to have geographically dispersed across all areas and weighted towards areas with the highest need.
Sue?
Thank you, Kelly. Just wondering, what are the links that we do, it linking into the shared needs assessment as carried out by local authorities and North West London ICB, that big comprehensive shared needs assessment? How do we link the two?
You mean the joint strategic needs assessment?
That's exactly what I mean.
Yes. So it aligns to, but it's not embedded within. It is a separate document, but actually it does allow us to do, again going back to what Leslie just asked, if we look at the Joint Strategic Needs Assessment, and we're doing a much sort of automated online JSNA now, which is much better than the tome of the document we had. That allows us to look at the health needs within the borough and across different areas of the borough. So when we start looking at the provision of that extended offer from pharmacies, not just as sort of the dispensing of medication, it allows us to think about, well, actually, if we've got higher levels of hypertension and cardiovascular disease in our more deprived areas, are our pharmacies in that area able to offer kind of sort of a widening that access and widening that offer to local people? So it just helps us. It helps us. So they should be considered together, but they are distinct documents.
On that point, when we tend to get the data of the immunisation rates, particularly for flu and COVID, but they're not broken down by those delivered by GPs and those delivered by pharmacies. Are we able to break that down? Because that would actually be very useful data to see exactly, A, what the difference is, and also the geographic variation by ward of where these vaccinations are being done and by which health agency is doing that.
We do have access to that information because they should be labelled under different codes as to who administrates that. What I would say is I haven't seen that data for a little while. It's amalgamated at that North West London level, and even at geographical level, sort of NHS England as the commissioners. What's quite interesting, just picking up on vaccinations, is that Hillingdon had the highest levels of, say, MMR vaccinations in North West London, but we also have a sort of a lower super output area with significantly the lowest uptake. So actually that information is in various places, so we can bring that together, but what I haven't seen is whether it's being delivered by pharmacists, particularly older people's vaccinations. Younger people's vaccinations is not usually done by pharmacists, but certainly older people's vaccinations, I haven't seen a disaggregation between what's being delivered by pharmacies and what's being delivered by GPs, but more what's being delivered in total in an area, or in a smaller area.
Tony?
Thanks, Keith. It's more a question for probably Eddie, Ian and others about and I feel like I should know the answer, having been at Wellbeing boards for all the years I haven't heard so many of these sort of assessments, but when we think about the distribution of resources in order to sort of meet the need, and we think about the kind of GP contracts and various other things, are we now thinking more about the role that pharmacists and pharmacies can have, and plotting that as a part of the kind of resource map for residents?
Who wants to pick that? Let's start with Ian, then Sue, if you want to chip in.
Yeah, so I suspect it's really started with COVID and the COVID vaccinations. So more and more immunisations are being given by pharmacies. And in fact, in many ways, modern pharmacies are much more entrepreneurial, and the NHS contract allows them to do more than the GP contract does. And there are various programmes, particularly Pharmacy First now, where GPs and actually patients themselves are actually encouraged to go as their first stop to the pharmacy for 7 common minor illnesses, and then there's a minor illness program where GPs can actually direct patients, and then there's an emergency prescription scheme where if patients have run out of their prescriptions and can't go to their GP, they can get their prescriptions from that. So there's a widening range. I think it's going to grow. There's an acceptance that pharmacists can do much more, and within the primary care networks are employing more pharmacists as what we call ARRS staff to perform medication checks, and then they often then go out into the community, both as part of the PCM but also being employed by community pharmacies once they've got all their qualifications.
Sue?
And just to add to that, as Ian says, since COVID, North West London Central Team as they're planning and preparing for the winter vaccine programme, and they're beginning to prepare for that now, they go out to practices and to pharmacists across North West London and ask them, are they wanting to engage in the winter flu, COVID and flu vaccine winter programme? And then when they say yes, we then have the list of pharmacists in particular and the list of practice who are engaging in the programme, and we can and do advertise that across North West London and available for Hillingdon website as well.
Go on, Tom. I'm going to give you the last word on this, then I'm going to move us on.
But it's a question. So
on,
it was going to be that. So do we know if we do it well? In terms of, because it would be sort of worth knowing. So if we do the things that we do they make a difference such that we can see the relief on sort of A&E front door or GP surgeries or whatever, because people are recognising it as an alternative go-to point, as their first point. Maybe not something to answer now, but it may be something for us to think about, because otherwise, how do we know whether it's worth sort of doing or not? But I'll leave that hanging there if no one else can speak.
I don't think we've looked at it from that perspective, but we've got very good data, actually broken down by boroughs across North West London about the use of particularly pharmacy first, and that's been taken up quite comprehensively, in the thousands in fact. What we need to do is actually correlate that with activity at general practice and UTCs and A&E to see whether it's caused a reduction in footfall there.
And we have the breakdown of vaccine uptake by pharmacists as well.
Okay, thank you. I'm going to move us on, if that's okay. Thank you for that. I think that is for noting, Kelly. So I think unless somebody screams and shouts at me, that is duly noted by the board. Thank you for that. Can I move us on to the joint Hillingdon Health and Wellbeing priorities for 25 to 28? I'm going to start with this one. I think then Kelly, you're going to segue. I'm actually going to make us work on this agenda item. You will remember, those of you who were here on the 26th of November, we had a development session, and that development session, we agreed that what we wanted to do was to be able to hold ourselves to account for the delivery of a coherent place-based health and wellbeing strategy, which was built on clear metrics and some streamlined integrated governance. And bluntly, there was a sense that we're all being too nice to each other, and that actually what we wanted is more grit, or grist, whatever the phrase is, in the mill. So this document is a starting point, and what this is, it serves as an initial draft. It's meant to provoke discussion. It's not a finished piece of work, because I've been to too many meetings where people haven't really read the papers and we say, yes, that all looks very nice, and then it never sees the light of day again. So what it is a synthesis, and sorry Faisal, it covers some of the stuff you're going to do. It's a synthesis of 5 documents, which is the North West London Shared Needs Assessment and Core 20 Plus Framework, the ICB Joint Forward Priorities, our own strategic priorities at a place, the Hospital Redevelopment Plan, and the Adult Social Care and Health Plan. And what I did is we fed that into a piece of AI, and we asked it to come up with some synthesis in terms of what the whole thing said, and what you've got in front of you is the work of a piece of AI with a little bit of adjustment here and there. Once agreed, these priorities, we'll turn them into the dashboard, because Tony, the question you just asked is, do we know if we do it well? And the answer to that is frequently we probably don't. And what we wanted to do is understand what good looks like, how we know when we're getting there, and allow us to challenge each other in a constructive way when things aren't being met, and some revised governance. And I think the important thing is the changes and the interesting discussions of the last week throw that, I think, into some interesting relief, and I'm sure we will come on to that at some point. So that's what the document does. Just in terms of what it says there are 4 challenges that we've got. One is about rising health inequalities, and unless we've been under a stone for the last 10 years, people will know that areas of particular deprivation in Hillingdon are in Useley, Hayes and West Drayton. And I could walk into ED department today, I think, Leslie, and ask where you're from, and they'll probably nearly all be one of those three areas. So it's not, I don't think this is rocket science, we all know this, although I have to say, Jane, the shout out to Harefield runs these three are close fourth in terms of areas of deprivation in the north. Just to give a shout out to the north in terms of where we are. 31%, there's a 31% child poverty rate and a high overcrowding and homelessness rate, and that ranks us amongst the highest in northwest in northwest London. We've got an increasing chronic disease burden, and these are the numbers that scare me, and they do genuinely scare me. Nearly half our population are living with at least one long-term condition. That's doubled since 2017. I'm sure Dr. Goodman Professor Goodman will correct me on it's basically a recording issue, but fundamentally most of our assumptions are based on long-term conditions of half that number. Top 5 long-term conditions are hypertension, anxiety, and depression. And we know that 4,400 people who live in Hillingdon account for 50% of all emergency hospital admissions. Small number, tiny, 1.6% of our population are driving that. Aging population, increasing strain on health and care services. The 65 plus age group consume 40% of all of our health and care resources, and nearly 50% of unplanned bed days for adults are hypertension related. The clue being, if we don't do something to intervene earlier and to do something with hypertension, that problem is going to get worse, and it's going to overwhelm most of our statutory services. Referrals to adult social care, 40% up in that period, and the spend on long-term home care placement costs has doubled in the last 6 years. And again, environmental and lifestyle risk factors, poor air quality, deprivation-driven obesity, high rates of anxiety and depression, they're all compounding that issues. I don't think, Kelly, there's anything new in that list that we haven't known before. And so what we tried to do in this document is to try and take a more focused look. We tried to avoid boiling the ocean in terms of trying to do too much. So there's 3 themes. One is about we need to strengthen early detection and intervention. We need to do more upstream. We are becoming an illness, certainly from a health perspective, we're becoming an illness service, and we're not doing enough upstream. Enhance preventative programs, particularly on hypertension, diabetes, and mental health, and we need targeted intervention in high deprivation areas, so Hayes, Useley, and West Drayton. We need to do some targeted work there. So the early intervention piece is something that I think, at the minute, and people may disagree, I don't think we've got a credible and coherent strategy in terms of how we're going to deal with that. And then there's the targeted care and support for the people with complex health and care needs, who actually are the 4,400 that we're talking about today. And again, whether we've got the right models in the right number with the right demanding capacity for that cohort of people, again, I think we're questioning that. So again, some environmental health initiatives, some data-driven performance metrics to measure and refine the impact. And again, there's a sense that actually we're not good enough in terms of measuring what we need to measure in order to track progress. Co-located one public estate, including a new hospital, and digital innovation and technology-enabled care. Something Gavin Fernandez has been telling me for at least 2 or 3 years. We don't do enough in terms of technology and digitalisation. And the things that have been happening, certainly, or will happen to the NHS over the course of the next few years, I'm fairly sure digitalisation will be at the front, will be absolutely at the front of that. So that's an overview. It's meant to provoke discussion. If I don't get any comments, I will be enormously disappointed in terms of that. So what we will do, Sean Barjow will tell me off if I don't say this, is what's key here is getting a nice handle on the metrics. So go back to, we want to build a dashboard, but we want to build a dashboard about things that we need to measure. And I think that's the critical, rather than the things that are available to measure and do two different things. So I'm going to shut up there. I'm going to invite Kelly just to say from the public health perspective, and then I will open it to questions.
So everything that you said, Keith, is absolutely true, and these are things that are familiar to everybody. These are discussions that we've probably had for the last 5, if not the last 10 years. And actually, I think one of the things that you didn't mention is that people are living longer, but they're spending more years living unhealthy lives, and obviously that creates significant demand for health and care services. And actually, in the document, we're showing a significant increase in adult social care. That will get worse unless we are able to deal with prevention at its primary cause, the primary prevention. And fundamentally, sitting around this table are the leaders of organisations, particularly the council, where primary prevention is absolutely our bread and butter. That ability for people to live healthier lives in their own homes, to be able to actively travel, to live in an environment where they're safe, the whole hierarchy of needs that people leave. And that really does have to underpin this, because on this level of the document that we're looking at, fundamentally, this is about being able to respond to demand, which is where we are now. We're reactively in response to the level of demand that we've currently got. If we continue and not tackle the prevention element, that demand is going to increase. That's where we are. So we need to really be thinking about what are the short-term things we need to do, what are the medium-term things we need to do. But if we want a healthier population, we have to have a quite significant focus on children and families, probably more so than we have done before, because fundamentally that's where the demand is going to increase, and we know as a population that the health needs, particularly of our children, are not getting any better. 5 years since COVID, and the discussion yesterday has really highlighted that. And in many of our plans, we've kind of recognised that we need to support children and families more. But also, as I said, it really is important to emphasise those social and economic determinants that really are fundamentally driving ill health. And in the document, it does highlight that sort of people's behaviour, the social circumstances in which they live, they grow up, they're employed, and then they die, should not be a determinant of health. But that is where we are. So we really do need to think about this as a kind of a longer term mission. We have to update this plan at least every 3 years. And Eddie, I know that when we had this for the conversation at the workshop, one of the things that you said, which was quite right, is that things don't change dramatically in 3 years. So we have to think about our priorities being for the longer term. And it really is good that we're trying to reduce the number, because we're kind of swimming in a tide of trying to do everything. But collectively, if we focus on the really key things that these documents sort of direct us to focus on, which are very much part of what the data tells us are the needs in this borough, we can make a significant change. So from a public health position, I'd support everything that you said, but really a real drive for action is really important here.
Anybody else? And if Tony's here and you've got nothing to say, I'll be really very disappointed on this one. Just to tee you up.
So I absolutely agree with what Kelly's just said, so full stop. However, I think there is, for one of the other discussions that we had about this board, is that we have tangible material things that we can focus on and hold each other to account for having done or not. Because within this there's still a lot of stuff that's like stuff that is day in, day out activity across a range of organisations. But what are and I'm just making up numbers for illustration, what are the top 5, 6 or whatever things that we will concentrate on, because they make this material difference, whatever we determine that material difference to be. Because the other thing that's kind of missing from it, not from this, that's unfair. Okay, this is just my view of the world, actually. And sorry to go back to the 18th century, but there is kind of something about almost like the social contract point. So so how do people consume health and wellbeing services in this borough? We are probably still a pretty traditional looking model of consumers in this borough. So how do we change that? And particularly, we've spoken about digital because it seems to be the answer to everything. It is an answer to a lot. I agree, but actually, is that the means by which a number of the people that we're talking about in the areas that you've just mentioned consume health services or understand how to access health services or information that's going to make them feel better or not? I don't know what the evidence is for that or not. So several points looped up in that. I think wider sort of public health point, and let's call it health literacy that we've talked about a billion times, absolutely stand by that point that we need to think about how we ensure that people can be smart consumers of health and wellbeing services. But for the purposes of this board, what are the small number of absolute killer points that we're going to hold ourselves to account on, showing that we've made a difference on? Because some of the dates, frankly, between 2 and 5 years, some of us are not going to be here in that period of time for a host of reasons, and actually is it meaningful for this board to be looking at the sort of 5-year horizon of something? Yes, it is in terms of the overall preventative, generational behaviour change point, but we need something more tangible to make us more meaningful, I think.
Okay, so I'm going to bring Jade in a minute and then go to Leslie. So I'm taking from that, Tony, that's a plea for, can we have top 5 or 6, can we percolate it down a little bit so we're really tightly focused on a small number of killer priorities? And obviously we're going to have a conversation, what are those killer priorities, but that's a conversation I think we need to have, because no one wants to boil the ocean here at all. Councillor Palmer.
Thank you, Keith. I really support this, and I suppose for me, representing the council, and Kelly quite rightly saying that, we have a part to play in this. I think the difficulty for me personally, I can't speak for every councillor, but bringing our residents with us, because I don't think they understand the importance that the council plays in their health. And I don't think they take it seriously. I mean, we get the green flags and we all go absolutely berserk about that. And we've got green gyms in some of our parks, but I don't think, without being disrespectful to our residents, I don't think they fully understand that what we're trying to do is to keep them out of primary care and essentially care homes and social care. So I think part of the work we need to do is to show them that we're not just moving things into the civic centre and doing nasty things with budgets. We are in fact trying to keep them healthy. So I think there's a big piece of work there. And also I was somebody that said that we'd lost our way here because when I first took this board over, we restructured it to make it less council top heavy, and that was successful. But what I'd really like to see is one really good piece of work that will help me support what I've just said, so that as a board we can show what we've actually done. And for me, it's obesity for a start off. I think that's what I see most of in my ward. So I'd like to think how we're going to do one really, really good piece of work and showcase that. And I think I'll stop there, Keith, because I've got plenty more to say, but others need to speak.
Okay, Leslie and then Professor Goodman. Leslie.
Thank you. So, look, I agree with what you said that says, glad you used AI, because we probably could have said these are the top priorities nearly everywhere, actually, but that doesn't mean we shouldn't keep saying them. The other bit, but there's a couple of other things I'd say, is I agree that I would say there's more than a small number of draft priorities here, and there is something that says we won't do them all. So there is something that says how do we get to prioritise those priorities to make a real commitment to doing very particular things. I was going to ask a question. It was interesting what you said, Jane, which was there's sort of something a bit paternalistic in this as well, and there is, which I get, but there is also something that says, how do we get what is normal behaviour? And the reason that I say that is anxiety is in here as a long-term condition, as is obesity actually, and I'm definitely out of date by saying, do we have a lot of obesity? We do. have we medicalised that by saying it's a long-term condition, and by the way, life makes you anxious, and that's part of the normal human condition as well. So the reason I'm saying that is not to be silly, but to say, how do we engage the population in what it means to be a normal human being, and what it means to be that says, and this is when actually we really do need to intervene to support you. And that's an adult conversation that maybe we need to think about. Actually, that should be one of our priorities about how we do that. I think there is a bit more that needs to be said about children. I agree with you. I think there's potentially something a little bit so there is stuff in here, by the way. And the other bit was around mental health and how we... I suppose if I was trying to garner all that together, which is how do we really ensure the people that do need interventional care are seen in their most therapeutic setting, because they're not necessarily that's not necessarily true right now. And I'll finish with a little bit about the acute unit, which says the acute unit needs to play its part in this. But and again, that is something that says really working together to say, what is the acute unit there to do for the population, and in such a way that when you end up going there, it delivers the very best care for you. And at the moment, we don't, because we're doing things that we shouldn't really be doing, and that means actually, I think, every day I think there isn't the very best care, and I'm not just talking about Hillingdon now, given in our acute units, because we're looking after far too many people that don't really need to be in there. And so where's that? And the really final bit is, so I get where this document is, but there is something that says, if we don't say who's responsible for delivering any of this, and I mean really who's responsible, if we say it's all of our responsibility, it won't get done, any more than if we don't put some form of timescale on, it won't get done. But thank you.
So I'm going to just summarise. I'm going to bring it in because I want to make sure I capture everything as we go along. So, support for small number of priorities. Good question. What I would like to is, my question will be then, so how do we prioritise? How do we get down to, here are our top 5 or 6? Because if I speak to different people, everyone's got a different view about what those priorities are. I spoke to some people from Children's Services, somebody was saying, it's children. There's got to be much more emphasis on children. So we just need to understand what the metric is for that. And responsibility, because at the end of the day, which organisation or are responsible for delivering that element of the plan within what time scale is again what I'm picking up. Ian.
So I'm going to be a bit controversial as usual. I mean working in the NHS is a bit like Groundhog Day, isn't it? We seem to address the same problems over and over again, and we don't come up with solutions. And I'm picking up what Leslie and Jane were saying. A couple of points. I think it's difficult not to be paternalistic at the moment. If we're going to get some results, because what we're saying from a social perspective, public health perspective, is putting all the responsibility back onto the individual. The earlier 19th century public health things were all done to them, sewage, water supply, that sort of thing. The public didn't have to do much. Now we've sorted those out, then those sort of things are much more difficult. And picking up Jane's point, I think obesity is probably more important than hypertension, and I'll tell you why. I think we undercode obesity and we overcode hypertension. So I suspect everybody who comes into acute sector with whatever it is, their blood pressure is measured, and if it's high, they'll be coded as hypertension. But that won't be the reason they have to come in. But we also weigh and measure a lot of them, but we don't put obesity down. And if you look at the data further down, inactivity is one of the key drivers. And when you're older, falls is the commonest reason for extended unnecessary bed days, and that's due to inactivity. So that's why I think obesity is probably the most important. I think we're in a stage now we're going to have these game-changing drugs, the GLP-1s as we call them. Now, they're very, very popular amongst all the celebrities. But they have been around for some time for diabetes, but they are going to be rolled out. And the NHS, for reasons that aren't entirely clear, are not allowing GPs to prescribe it to obese patients, only to diabetic obese patients. And it's not clear why, but it will be rolled out slowly. But over the next 2 or 3 years, I have no doubt that just as statins were rolled out and almost anybody over 50 is on a statin now, I think anybody over 50 who is overweight will be on one of these drugs, because not only does it lower your weight, it reduces your heart attacks, and it also, there's evidence that it prevents dementia as well. So these are going to be the next range of universal drugs used. And that's going to be a game changer, because if we can keep people in a narrower weight range, keep them more active, they will have a healthier life in their later years. But at the moment, one of the reasons that we can't get our residents more active is because they feel they're overweight. When I talk to patients who have osteoarthritis particularly, which is a huge burden, it's because they're overweight, and that's a vicious cycle. They get overweight, they don't exercise, their joints get worse, they exercise even less, and they put on more weight. I think that's something that we should actually look at and plan for, because it's going to happen, and we need to be aware of it.
Thank you, Ian. Eddie?
Well, firstly, when it comes to the delivery model in a lot of this work, the number one item on there is integrated neighbourhoods, which I'm grateful for, because I think that's the right way of looking at neighbourhood working as being a delivery model, actually the delivery model that we need to move towards. And in some ways you've got neighbourhood work in certainly from healthcare, but as we work more and more closely with social care, you've basically got neighbourhood working and the acute trust, and that's almost it. The other thing to point out is that at a neighbourhood level, you've got different flavours of the entire strategy, but at a neighbourhood level. So if I look at the southwest, we've got anxiety and depression and hypertension as priorities. If I look at the southeast, you'll have obesity as a priority. Look at the north, you'll have slightly different. I mean, they're all they are adjusting to the needs of the neighbourhood population, and we all know, particularly north to south, that our population varies, and so the neighbourhood, you almost have a health and well-being for each neighbourhood, and the components of which make up the entire borough. So the other reason for saying that is when it comes down to chunking this up into targets, I think at a neighbourhood level it chunks up into targets much better, because your neighbourhoods are more focused on, let's say, 3 priorities within each neighbourhood, rather than have 9 across the whole borough and it all feels too much. So I think if you look, there is an element to this where I thought, actually, we've got quite a lot of this progressing already within the neighbourhood plans, and they dovetail quite nicely.
Thanks for that, Eddie. I think my big fear is that we boil the ocean. Is that what we do? Is that we try and take on too many things, and that we don't deliver on anything? I think is the key thing. So I think what we need to test Eddie on that is personally, I'm keen that we focus on 1 or 2 things which actually we know will drive the sort of change that we want. Because just in talking to people just over the last week, everyone's got slightly different views of the world, and I think that's the bit I'm just a little bit nervous that we will end up doing lots of things in a very, excuse me, Tony, in a very NHS way, which is we're doing a lot of work but not moving an awful lot of things forward at any one at time. I'm not being rude to my colleagues in there. I'm going to go to Kelly, I think first, then back to Leslie.
Just responding to Ian's comment, I do think that the, can't ever remember the acronym, but tirzepatide, Wegovy, or Onjaro, or what, GLP-1s, I never get the acronym right. I do think there's going to be a big system-wide change, but it's not going to happen very quickly. So I think over the next 3 years across all of the ICB areas, there's going to be 220,000 doses, which actually, if you think about the criteria, whatever the criteria is going to look like, and it won't just be for diabetes, there's a hell of a lot of people that are eligible, so it's going to be a tiny number of people over the next 3 years that's going to have access to this. But actually, my real concern is it becomes a default position. So actually, we've already failed people if they've got to that stage where they're going to need that level of that degree of intervention. And yeah, the cost is going to come down eventually, but actually people are going to be living or getting worse before they actually get to that stage. But fundamentally, in the document, it really does need a focus on prevention, because prevention is much more affordable than cure. We know that. That's already well established. But to the fact that there is a default position should not be our driver, albeit that for those people where the current demand is, it could potentially will have a significant impact when we can apply it to the level of population that we currently have, who actually probably are eligible for it. When you look in this document, we're going to be nowhere near that, certainly in the next 3 years. I don't know what's going to happen after 3 years, but 220,000 doses across the whole of the country in the next 3 years is a very, very small amount. So for the here and now, we really have to focus on what is it that's driving the ill health within the borough, and how do we prevent the causes of the causes.
Okay. I'm going to go to come back to you if that's okay, and then I will give you the final word on that matter. Leslie?
Yeah, I think the discussion about what we do in neighbourhoods is an interesting discussion, because there is a risk that says if we devolve our money equally, we use our money equally. Actually, in some bits of the borough, we could do some very nice, trendy things, and for other bits of the borough, our most deprived people don't get very basic stuff. So I think, maybe not for today, but at some stage, it's quite an interesting discussion that says, should we do all of these things differently, or should we concentrate on the work that we need to do in the most deprived bit of the borough, controversial as that might be?
I'm not sure that's entirely controversial, actually, on that one, but I think you're right. There is a shift from, isn't there? Let's do everything for everybody to should be target that, particularly in a resource-constrained environment. Susan.
Apologies for my lateness. I just have one comment. I was just looking at the key challenges, and for me, as everyone has, well, not everyone, but most people around the room have said, we've been talking about a number of these issues for very many years. My biggest problem with it, from what I see, is that, again, it's a little bit Groundhog Day, I think, for the council and for anybody that sits on these committees. The key challenge is how do we engage with people? That's the most striking thing. We know that people are... I know I'm a little bit overweight. I know that I should be doing certain things. I know I can be inactive. I mean, I'm struggling to engage with this as well. If you have people that don't speak the language, and there are people that just don't have, great ability to access information. I've been to events where we have no smoking. I've been to events whereby we have a roadshow on brushing children's teeth. It's just not getting through, and I think our largest challenge here is how do we engage with our residents and our clients.
Completely agree with that one, Susie. Absolutely agree. And I think that's the challenge. I think what we try to do here is, to be honest with you, we don't know the answers as we sit here, but we need to find them. I think is the issue. Right, I'm going to Kelly, then I am going to give the very last word to Sue Jeffers, then I must move us on. Kelly.
I'll probably segue to Sue, actually, because I think I know what she's going to say. I think what Leslie said, we do need to, it is inequalities. That should be fundamentally the foundation upon the work that we're doing. Don't just think we should be focusing on just the neighbourhoods which are the most deprived. Sue will tell us about the communities. There are communities that just do not do well, who we are letting down. And I agree that the first point does need to be, how do we more effectively engage with people? But I would just say that there is a point at which people still smoke, yet they know that smoking is not good for you. So I think there is just something about how do we communicate and have direct conversations with people, because I think sometimes we slightly to take approach that we don't want to upset people. We don't want to talk about obesity. We don't want to use the F word. We don't want to have direct conversations because we're concerned that people will be upset. You know, and even in maternity services, when we look at maternity services, we know that high obesity levels amongst women who are pregnant leads to poorer maternal outcomes, you know, yet we don't have those conversations. So fundamentally, I think if we even if our starting point was to focus on the core 20+5 work, we would be taking a really good dent at some of the issues that we have. And that segues over to Sue.
Thank you very much. I'll pick it up. Again, following from what Kelly has said and from what Leslie has said, we have, as an ICB, we have a statutory responsibility to focus on the core 20+5 groups that are most impacted by health inequalities. As an ICB, we are just in the process of kind of refreshing in each of our local authority areas which core 20+5 groups we want to really focus on, and I think following from Leslie's, we have a slide in the pack on it, and I think following from Leslie's, we actually have a responsibility to focus on our most deprived communities, and I think that and finding ways of engaging those communities that they come with us on a couple of core things like the improving activity, the management of obesity, improving nutrition. That's kind of it. We don't need to go much further than that. We've had in the last year, doing some work for the health inequalities funding piece, we've had in the last year a 15% rise in homeless people since December 24 to January 25 in Hillingdon. So it's a really significant issue. So we've got in our pack the core 20+5, and I know this document is up for debate. I would like to add to this asylum seeking communities and our refugee communities, and we've got our homeless communities identified here. The third one we have here is around our LD community, but actually I wanted to just have a think about focusing on our children, our most vulnerable children and young people, potentially as a core 20+5 group. I did engage with, as well as engaging with public health colleagues, I also engaged with Health Watch colleagues and asked them the question which areas, and they came back with our children and young people, particularly our vulnerable. So looking at our neurodiverse communities, children in poverty, young carers, children with mental health, our looked after children, our LGBTQ plus and trans communities as well. So just thinking, so it's a proposal really for us from the Hillingdon in terms of our part in the North West London refresh of the core 20+5.
Thank you. So I'm going to try and summarise what I think we're saying here, and I'll come back to your proposal in a moment. So unless you tell me otherwise, what we're doing is we want to prioritise five or six, half a dozen, doesn't matter, not get semantic on it, of priorities that are going to make a significant difference. The proposal one of the proposals we've had is that we do that through the most deprived neighbourhoods, a focus on those most deprived neighbourhoods, and the core 20+5 areas. So that's one of the proposals, and the other thing Councillor O'Brien was suggesting is that underpinning all of this is a need to look at how if we're going to take on the prevention agenda, is how do we engage? Is what's going to be different this time to what we tried to do in previous times? The question is that a reasonable summary, and the question I'm going to ask you before I move us on is how do you want to prioritise? How do you want to do that bit of work? Tony.
I'm not going to answer your question directly, but we need to decide what it is what's the point of what we're prioritising. Now, clearly, there's an obvious starting point, which is to improve people's lives, but we're at a financial cliff edge, so we probably just need to take some time out of this to have a think about, because some things are going to be about finance, some things are going to be about, so what is the biggest difference that we can make that is going to make a difference to us financially, in order that we can do other things, because at the moment we're chucking the same money at a range of things we chuck money at. So I don't think we've got enough here yet to be deciding that. We need to set some smart criteria around what it is that we're prioritising and why, because otherwise what we will do is say the same things that we say every time, and that we've said probably for the last several years. Or the priority areas, yeah, we know that. And I'd go back to Eddie's point, some of which I kind of agree with, but I would challenge ourselves back to say, I've sat in I don't know how many meetings about population stratification, risk stratification across communities, areas and whatever, and when I say what's the difference, I'm not saying there's no difference, I'm genuinely saying what's the difference, so that we can then prioritise the areas that are going to make the biggest difference for us. Because otherwise there is a danger we'll just go through a whole big exercise and come out with the same top 5 things that we have every time. Whereas I think it is about specific activity, things that we are going to do, with a clear evidence base that it's going to, say there's this amount of money, make that much difference to the number of people turning up at A&E or GP surgeries or whatever. So we just need to decide the criteria for what it is we're deciding as well as what it is we're deciding, if that makes sense.
Yep, okay. I could probably do that in about 5 minutes, but yeah, but I think you're right, Tony. I think the question is, what are we trying to achieve here? Yes, we're trying to make people well, but if we don't do something different and people keep turning up at front of the, we will not have a new hospital in Hillingdon. It could be as simple as that, because we'll have one, but it won't be big enough. It's just adult social care may well be overwhelmed. So it's just understanding, as you say, what's the exam question we're trying to answer, but the core to that is we can't just keep building intensive care units. This is a metaphorically, keep building intensive care units to cope with the people falling out of the sky. We've got to do the air traffic control as well. I think that's the bit we've got to try and do. So it's an offer. I'm happy to take that away and have and come up with that, because I don't think that's a complex bit of work. But equally, I don't want it to turn into a 6-month project group who look at the things we've looked at for some time. So the offer on the table is I will take that away and come up with what I think those exam questions are. Thank you very much for that. Yeah, happy to help. Kelly, I nearly went to you then, Gavin, because you were smiling at me, mate. Yeah, Kelly.
Just to reinforce that the core 20+5 would actually deliver. If we were to do this properly, and having just done a big piece of work elsewhere, if we were to really look at the core 20+5, but the core 20+5 for children as well, because there is a separate one for children. If we did the adults and the children, and we focused on the 20% most deprived areas of the borough, applied these principles, these are fundamentally the areas where we're going to get the biggest gain from.
Anything else? So what I'm going to do is I am going to corral a tiny group of people here just to help me very quickly craft what those exam questions are, and I will just nominate you if you don't mind, because I don't think this is a big piece of work, but it will involve you, Tony, it will involve you, Sandra, and certainly Leslie and Eddie, involve you just to have that conversation, because I don't think this is that complex to have. I'll take that as action. Thank you. Right. Sorry to keep you waiting on this issue.
That's all right.
So can we, if you are content, and I have got my agenda item right, which I have done, do you want to take us through the North West London forward plan? Someone has to. You might as well.
It might as well be me. Can I just ask how much time we've got? How are we doing for time generally?
We have grossly overrun, but that's my fault, not your fault. So how long do you normally need for this?
Not very long. I'll try and run.
I'll give you 15 minutes and then we'll see how we go.
Okay. So thank you for having me. So over the past few months we've been refreshing our joint forward plan. So I'm here to give you a bit more context on the plan, summarise the plan itself very briefly, but also go over the next steps, and it'd be great to get your thoughts on the summary. So it's not a final version and it's still considered draft, so what I'm going to do is present on screen the summary of the plan, but then we'll also send out the full document following this meeting for comment in writing, because it's currently a draft version, and before we finalise it we're happy to take comments from a wider group of people. If you don't mind moving us on, Nikki. Oh, I do. Where? I think I might have put it in my bag.
That's the ICB for you. Look, they come here, they take your resources. They don't.
I thought it was mine. Is this it? Oh, yeah. Well rehearsed. So just to kind of give you a bit of background on what the Joint Forward Plan is and why we need it. So the Joint Forward Plan is actually a 5-year plan that's a statutory requirement for all ICBs to produce annually, and that's in partnership with their NHS provider trusts. So the joint in the name refers to the ICB and the providers in the patch. That being said, outside of the statutory requirement, we're facing a number of challenges, for example, significant financial challenges and operational challenges, which I'm sure you all are very familiar with. So the Joint Forward Plan allows us to essentially set our long-term strategic direction in response to these challenges. It allows us to do a few things. It hopefully gives some clear strategic direction to our staff. It gives our teams the license to do fewer things well, rather than try to do everything at once. It allows us to identify and remove duplication between all the work that our programme teams are doing. And finally, it allows us to track our progress more consistently as the years progress over that 5-year period. I'll very quickly go over a number of challenges that the Joint Forward Plan is aimed at trying to solve. So every planning document or strategy document usually starts with a statement of the challenges we're trying to solve. So number one, as you know, the nature of the care our population requires has shifted quite significantly. So it's now driven, care is now driven increasingly by an older population, which brings with it kind of multiple long-term conditions, and that shifts the type of care required from acute to chronic. As we know, improvements in life expectancy have stalled over the last 10 years, and in some cases have actually started to decrease. And as Kelly said earlier, the healthy life expectancy itself has decreased quite significantly. Number three, we're starting to see the shift in our population's needs in our recent activity trends. So we're seeing a massive increase in demand in primary care, at about 7% a year. And we're also seeing a massive shift in acuity, an increase in acuity for the attendances that we're seeing within our EDs. Number four, we've talked about this quite comprehensively today, but we also have significant variation across North West London in service availability, access and population health outcomes. So the Joint Forward Plan aims to address some of these variations. Number five, the pressure on our system will continue as our population continues to age. So looking at the population projections, we know our over 65 population will increase by 17% over the next 5 years, which is quite a significant increase, and that will bring with it kind of all those additional care needs I mentioned earlier. And then finally, number six, we know the 10-year plan is being drafted as we speak, and three kind of big shifts have been outlined: sickness to prevention, hospital to community, and analog to digital. And the Joint Forward Plan aims to deliver some of those things over the next 5 years. I'll skip over the next slide, which is around kind of the process for the development of the plan, and kind of focus on the kind of the 9 priorities themselves. So our latest Joint Forward Plan has 9 priorities, and hopefully you recognise these being the same priorities as they were in last year's Joint Forward Plan. So we have made minor edits, and we've done a bit of reordering and theming so that they're kind of slightly easier to digest. What we have focused on this year is, instead of doing a full refresh of the Joint Forward Plan, we've done a light refresh. So we kept the priorities the same, but we've focused on the actions that come under each of the 9 priorities. So other things that we've done is we've prioritised actions within those 9 priorities. We've also deprioritised initiatives where we think a lot of effort is being placed into initiatives that may not have ultimately as much value as we may want it to. And we're also tying our priority to the North West London Shared Needs Assessment, which builds on the individual joint shared needs assessments across North West London. So there's a bit of alignment in really understanding what our North West London population requires and how we actually strategically deliver against that requirement. So as you can see, our 9 priorities are kind of grouped around 3 key themes. The first theme is around integration and providing proactive joined-up care. So our 3 priorities within these themes are hopefully quite familiar. So the first one is around establishing integrated neighbourhood teams. So that aligns quite nicely with some of the discussions we've already had, but also some of the shifts outlined in the 10-year plan. We also want to reduce inequalities through population health management approaches, and we think integrated neighbourhood teams are the delivery vehicle for making that happen. And then finally, we know lots of improvement is required in improving that patient flow through the system so that patients get the right care in the right place at the right time. As Leslie mentioned earlier, we know there are lots of people in our key hospitals who don't need to be there. So this aim is around improving that flow across the system. Our second theme is around consistent, high quality and efficient community and mental health services, particularly for our children and young people. So this theme speaks to our ongoing work on providing a core community offer that's consistent across North West London, that all residents have access to regardless of where they live. And we think one of the key ways of making this happen is to actually start with improving the productivity of these services so that capacity can be shared more equally or more equitably across the patch. Number 5 is around doing this in particular for children and young people. We know intervening earlier on has massive benefits downstream. And then number 6 is around improving mental health services in the community for all adults, but with a particular focus on people in crisis as well. And then finally, our final theme is to transform specific services. So in this case, maternity, cancer services and planned care services. So maternity was chosen in this particular case because we know we need to improve outcomes, and in particular we know there's significant variation depending on which population group you come from in your maternity outcomes. Cancer was chosen because we know we need to improve screening, and in particular the variation in screening, and we know we need to do better in providing faster access to diagnosis and treatment. And then finally, planned care was chosen because we do have an elective backlog that we've made huge progress against this year. But we know there's further to go if we're to hit the 2029 constitutional target that the government has outlined. So that's our 9 priorities grouped against 3 key themes. What does that mean for Hillingdon? Actually, before I go into Hillingdon, so there are some staging of our kind of activities over the next 5 years. So in kind of years 0 to 1, we do want to focus on embedding our core offer and levelling up all of our services across North West London, and recovering productivity is a key way of making that happen. In year 2, we want to tailor our core offer to local populations and improve quality. And in years 3 to 5, we want to focus on innovation and developing new bespoke services. So years 0 to 2 are really about getting the basics right, having as little unwarranted variation as possible, and then years 3 to 5 are where we start kind of transforming our services through innovation and new bespoke services. So what does that mean for Hillingdon? Apologies for the font size on this slide, but essentially there are some similarities in Hillingdon's overarching plan. So as you know, there's a vision to have a 7-day place-based operating model through 3 integrated neighbourhood teams and a single borough-wide reactive care service. 3 priorities sit underneath that: integrated neighbourhood teams, optimising system flow so they align nicely with the 2 North West London-wide priorities, and then another priority on end-of-life care as well, focusing on a palliative integrated care service and developing the key to hospice pathway. Just moving on to the final next step. So, as I said, the joint forward plan is a draft document in its current form. I'll share the full document following this board meeting. And there's also further changes to be made to the joint forward plan to reflect our latest work. So we've got a lot of work happening on urgent care, and our strategy is being developed around that area. We've got a lot of work happening on our planned care area, and our strategy again is being developed. Once those are more mature, we'll then make those changes to the joint forward plan so there's consistency in all the planning work that we're doing. As you know, we're also going through operational planning at the moment, so once that's finalised, again, more changes will be made to the joint forward plan to bring that into line with kind of our immediate year planning work. That's kind of the end of my presentation. I'm very happy to hear kind of questions or comments, but as I said, I'll send round the full document. I'm very happy to receive comment in writing following this meeting.
Thanks, Faisal. And what is it you want from this? Is it to note? What is it you want?
No, any kind of immediate feedback or kind of more general feedback, and then more detailed feedback in writing following the meeting.
Any questions and comments? Quite a few of us have, and this is not rude, been around this loop on this issue quite a few times. So, Leslie, do you want to say anything?
Oh, I'm sorry for throwing that as well, sorry. Look, can I ask, who's this for?
It's for the ICB and the NHS providers.
Okay, because the first page that says we're doing this because we've got an ICB reorganisation, if it was for more public consumption, I think it's probably the wrong way round. I would start with.
So the presentation isn't for public consumption.
Okay.
The full document is. That was just context.
Okay, I think that's helpful. I think so it does mention children's mental health and community services. Thank you. And I think potentially I'd be a bit more specific around that, around dentistry and some of the other things that we really do know have become a massive problem. And then in the context. In the framing of it, there is something that's maybe that says if it's a wider consumption, that goes back to the reason we've got increasing waiting lists, the fact that we've got an ageing population and the ED performance and whatever, and also the financial constraints is probably just one thing.
Yeah, the plan goes into further detail. It's about 90 pages. It's all very comprehensive and interesting.
Keeps you out of trouble.
It keeps me out of trouble.
Tony.
Thanks. I just thought it was quite interesting seeing this following the conversation we had previously, because it's kind of at odds with a number of things that we came up with. Sorry, it's not a criticism of you, but personally. It's because it's almost talking about that kind of universal level of sort of coverage, and we were talking about what are our big drivers of cost. I'm using that as one example, or what are the significant drivers of people's ill health? Well, actually, aren't they at odds with each other?
I think you could say.
You don't have to answer. I'll leave it rhetorically floating.
I'll ponder
I think
it for a
that's the
second.
question I'd push back to, and which comes back to, is it the top or the bottom that can determine where those resources are best focused?
Yeah. Can I just quickly come back on that? So I think what we're really trying to say with kind of the core common offer work is that we find that some of our population don't access the services in the way we'd like them to, or may not have access, or may not have the right services in their location. And what we're trying to do is really equalise that across the board, across North West London, and hopefully that will, in the same way what you were saying, Kelly, kind of reduce the variation, and then reduce the variation in services and reduce the variation in outcomes downstream.
So, you see, I don't think that's a common core offer. I think it's a very specific, tailored, focused offer in order to in order to bring that levelling up. So I think there is something about language there, because you would be focusing on those dips to get them to a normal rather more. So I think there is, again, I think it comes in.
Sorry, I think it comes in the sequencing. So I do think there's a need to kind of have a common offer, but in year 2 we do say, we do need to tailor our core offer to local populations, add additional services where they're required. But that kind of equity point is quite core to what we're trying to do here, if that makes sense.
Right, I'm going to let Eddie speak and then I'll go to Kelly.
So I guess I'm going to touch on one of my favourite issues, which is the core common offer. I don't think that's the right way round. You want common outcomes, and you want equality of outcome. And we've already been talking about the different needs and populations in Hillingdon, and maybe we ought to resource at a local level to those populations. And the problem with this is as I feel it, is we get a common, community nursing specification, a common this specification, that specification, and it fits a community somewhere in northwest London, which is the average, and not anything specific. And it doesn't seem to sit very well with that localised neighbourhood. How do we use our resourcing in our neighbourhood or borough to best effect to meet the outcomes? So I don't think it comes out in what you've presented it, but what I feel we see as a product from the strategy is something that is actually over-specified in terms of input. And I think that's the danger with where this is heading, if I may. And because some of what we're trying to do locally within the strategy of how we put our pieces together, it is quite specific. I mean, it is because we've got a new hospital and a geography where the hospital has 70-75% of all of its activity is co-located with the borough, which is co-located with the community services. The way it is pieced together in Hillingdon, and this disrupts, I sense, what we do as a place.
I'm going to bring Ian in, but I think this goes back to the discussion we had at the board away day on this, where Penny is moving on to bigger and better things, isn't she, I think. And it was the point around neighbourhood specification versus a specification for a particular service. You have a neighbourhood specification, you can use your workforce flexibly. You have a specification for, community nursing. Then what that ends up getting is, well, this is what's in the specification, I ain't doing anything more than that's in that. So it's how we use our workforce flexibly, I think has been an issue for that. But I think that's a discussion that's going to run, I think, this one. But I think the more tightly we restrict our workforce, the less we'll drive the benefit that we've got. I will let you come back, but Ian has been very good, and he wasn't jumping in. Ian, you next, and then I go to fight. Then I will draw a line under the.
I apologise for channeling my inner Tony on this question, but when I look at this and I compare it with what you and Kelly presented, it must be somewhere, but I don't see what your outcomes are and what the milestones for those outcomes are, and I haven't seen them published from last year's, because this is something that I raise every time I present it. For the past 2 years you present it, but I actually haven't seen there are any outcomes, any benefits from this strategy, and that needs to be front and centre of any strategy, and it just doesn't appear to be there.
Okay. Faz, I'm going to respond to that, then I will give Kelly the last.
So I guess it's the challenge was trying to boil down a 90-page document for a 10-15-minute presentation. There are detailed outcomes and milestones in the full document, which I'm very happy if you go through and provide feedback on. The full document has a quite comprehensive set of those.
but you should be visiting these every single year to see how you've done year on year.
Right, I'm going to guillotine you, Professor Goodman. Sorry, it's yeah. I can see where this one is heading. Yeah, but yeah. Thank you. I'm going to give Kelly the last on this one.
So 3 points, and they'll be quick. And I've said this before. It feels like this is a strategy or this is a plan for the NHS, and it feels like it's the NHS for the NHS to the NHS by the NHS. Okay, but we've got this document that our plan today that says clinical care access accounts for 20% of health, and it's kind of like, when are we going to learn that actually you can't have a functioning hospital without a functioning social care service? So how do we make the ICB recognise this and do it together? That's my first point. My second point is, we talk about prevention, but I'm never entirely sure that prevention is properly understood, whether it's primary, secondary and tertiary. And I'll be really honest, apart from outside of universal cancer services, and well, I'm not always entirely sure that vaccination is done particularly well, but we kind of don't do prevention properly, particularly secondary and tertiary prevention. And I just wonder whether this is an opportunity to start thinking about what does prevention really mean, and how do we make every contact happen, be a preventative one. Things like, really properly stop smoking services, really properly doing something like that. And the third one is just a little bit of incongruence here. None of those 9 says end-of-life care, but our Hillingdon one does say end-of-life care. So I picked up the end-of-life care on a previous iteration and said, why is it not there? Really, people need to have proper planned care for end of life, but too often it's an emergency. We're dealing with it because we don't plan it properly. We don't have enough resources. And actually that requires adult social care to be part of that factor. So, the NHS has to at some point recognise that you only count for 20% of health, but let's not pretend that this joint forward plan is going to deliver health, because it can't do that. So just a bit of reflection, because nothing ever changes on that front.
Okay, what I'm going to do is I'm going to allow my co-chair to have one final thing, and then I will move us on. Thank you, Faisal, for...
Very wise. Thank you, Keith, for letting me speak. Yes, having sat on the Integrated Care Board from the start and worked really hard with our health colleagues to become a joint board. At the start it was very council, very health. It is now, I'm proud to say, an excellent integrated care board. I am disappointed that we are still trying to fight the case for social care, because it's blindingly obvious. And when I look at a document like that, it takes me back to 2 years ago when it all began. I think we have to accept that we are sitting around this table as one big group of people wanting to do the best for our residents. And quite simply for me, none of this, I can't be doing with it all. My health colleagues know what the heck is going on with the health of my residents. That's quite simple. I'm not an expert in health. I'm more of, I won't call myself an expert in social care, but I do understand what needs to be done to make it, and it's as simple as that. And no amount of these wordy documents is going to make me feel any better when I leave here. In fact, looking at that, I feel absolutely worse. So I think we're never going to get it right. We've got to start somewhere, and when we start somewhere, we're going to exclude everybody else. If I start with a child, I'm going to exclude an older person, but I can't help that. I have got to do something here to make people in this borough feel better and live better lives. We've got to start. We've got to stop talking, and we've got to get on with it. And I'm hoping that with Keith's little group of people, we're going to start to do that. So no disrespect to that, but I will say we've worked really hard in North West London to all come into one thing, and I wouldn't want to see that go back again, because it was a nightmare before, and now it's a pleasure to sit round the table on that integrated care board with my health colleagues. Sorry for the rant, but sometimes I just need to get it out.
Thank you. First of all, thank you, Faisal, for coming, and thank you for, because obviously you've stimulated a lot of discussion, so whether it was a stimulation you wanted is another issue. But we have a dark room you can lie down in over there if you like. So first of all, we will feedback. I think, Nikki, just in terms of the comments that we made here, so that you've got some feedback. But I think that you've heard the tone of the meeting about the balance in the document between health and social and the wider determinants. But we have contributed to this, so we have to own it too. So thank you for coming here, and send our best regards to Toby, won't you? When you see him. Thank you. Right, can we move on to the non-controversial subject of the Better Care Fund? Who did the agenda for this meeting? So we've got a wider discussion on the Better Care Fund in the next part of the meeting. So I think this, Gary, is about the 25-26 plan that we're about to go into. So do you want to put your head into the mouth of the lion this time? Thank you.
I will, Chair. Thank you. Yes, what you've got before is about the 25-26 plan, the planning requirements for which were published on the 22nd of January, and the submission date is the 31st of March. Unfortunately, it's not been possible to conclude all the processes necessary to bring the completed plan for your consideration at today's meeting. Hence, the request to the board to delegate sign-off arrangements has been the case in previous years. Just a few points to highlight, Chair. This will be a one-year plan. What's actually going to happen with the Better Care Fund is, I think, actually going to depend on the outcome of the Casey Commission into the future of adult social care. There are two objectives within the plan that are not dissimilar to what we've seen in previous iterations. Although with greater focus on prevention and early intervention, particularly within an integrated neighbourhood team context, and also around supporting independence. In terms of some of the income streams, we've seen there is an increase in the minimum NHS contribution, including to adult social care, and also to the disabled facilities grant allocation, which again contributes towards supporting people in the community. What is particularly notable about the other income streams, which haven't changed, but the ring fence that was on what was previously designated the discharge hospital discharge funds has actually been removed, which creates some opportunities around what we can do on emission avoidance. What we've also sought to do within the plan is actually implement some of the findings from the North West London review, which we'll talk a bit more about later. Chair, I think I'll leave it there and happy to take any questions the board may have.
You'd have surprised me, Leslie, had you not put your hand up. Leslie, do you want to?
So thank you. For those who don't know, I'm also the NHS England lead for discharge and flow, so thank you. So I think hopefully what you can see, Gary, and others, is that actually that the time taken normally to judge the plan, the BCF, we've tried to say we're not going to judge the plan, but what we do need to understand is there is an expectation that this plan does result in less patients who would have come to hospital coming to hospital, and a much quicker discharge of those patients out of hospital into an appropriate setting. And it is the outcomes, so we were talking about outcomes earlier, it is the outcomes that we will be judged on, rather than the fact that we put together a plan that somebody's gone through and looked at every line. But I had a look at this. I think the plan in and of itself looks good, actually, so thank you.
Any other questions on the 25-26 Better Care Fund plan? No. It's probably just worthwhile saying, just to complete the conversation we've been having today, is underpinning this submission is a demand and capacity review that we are working together on collectively, and we should have finished that particular piece of work by the end of March, or the next week or two. And what we will do is we will reflect back the outcome of that in the plan. So just to put that for the minute, I think, Nikki, on that one. So what we're asked to do on this one, if nobody else has got any comments, is one is to note the contents of the report, but actually to agree to delegate authority to sign off the 25-26 Better Care Fund plan, including the proposed financial arrangements for the national metrics to corporate director, to Sandra, and Jane and myself, and the North West London ICB, in line with governance. Are people content to so delegate? Sorry, thank you for correcting me on that. Sorry, Lynn, didn't mean to including Healthwatch Hillingdon as well. That's okay. Yep. Yes, that's approved. Thank you. And then finally, in this part of the meeting, can we move on to the board planner and future agenda items? Nikki?
So, Chair, we have the dates now for the 2025-26 meetings. They have been amended slightly in terms of moving the November date to December. We don't have anything significant on the board planner for the next few meetings, so I would like some suggestions of what we're going to be having on there.
Any suggestions? I can think of quite a few, but I've talked enough at this meeting. So, anyone other suggestions that people want? Well, the Better Care Fund review is one, the formal outcome of the Better Care Fund.
Chair, will that be on every meeting, or will there be some standing items going forward? Because I know we're actually shaking up the way that the board performs.
So we need to bring the formal outcome of the Better Care Fund review to the next Health and Wellbeing Board. Kelly?
Previously, we thought the combating drugs and alcohol work. It's now called the Drug and Alcohol Treatment Recovery Improvement work. It's been rebadged. It'd be really good to bring that. Sorry? Yeah, June will be great. And it also would be really good because we haven't had stop smoking for quite a while, and now we've got the new grant. That would be good as well to bring. And on top of that, we might bring together sort of a little bit of a sort of a, little bit of a sort of a pot of things. Oral health. I know that Sue talks about oral health, but we've now got the new supervised, from April, the new supervised toothbrushing amount of money will come into the public health grant. So we can pick that up. I'm happy to do that in June as well.
And then finally, Nikki, I think what we will, not finally, but for me, is obviously we'll bring back a health and wellbeing strategy with the changes that we just discussed at today's meeting, and that will be supported by a new dashboard that we'll use to track progress.
Will we need a paper when we know more about the impact of the NHS reorganisation and how it's going to affect our local health economy?
We'll pick part of that up in the next in the next section, but absolutely yes, and that'll be tied into revised place-based governance, I think, because I'm almost certain that's one of the things that will change. So yes, Ian, it'll be. It may not be June, but let's see. Leslie?
Would it be helpful for us to understand what the new community offer is and the community services and how that builds on our intent to look after patients in a different way, in a different setting, because around the strategy of the new hospital, but also all the work in the community and how it impacts particularly into neighbourhoods as well, or the other way around, how that translates into what neighbourhoods would want to see. I don't know, but...
Sue, do you want to...
I think yes is the straight answer to that question. I think it's a good thought to have it. they are still all in draft and discussion and thinking. So I think, as Faisal said earlier, I think it's the sequencing issue for me, and what is the timing, and it needs to potentially link with our progress on our integrated neighbourhood teams. I wouldn't want it to be a separate item from progress on integrated neighbourhood teams.
That clear, Nicola? Thank you. Anything else? No. Okay. That's noted. You don't need any seconding on that, do you? You think you've got enough steer. So that's the end of the public part of the meeting. Thank you to those members of the public watching on YouTube. Will everyone please remain silent until Democratic Services has confirmed that the live broadcast has ended and the loop has been switched.